Being able to move is important. Moving without excess pain is wonderful. Oh, them bones. Orthopedic issues tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. They may appear quickly with a misstep or a fall, or they may progress at a glacial pace over years. Problems with your bones can cause pain, loss of mobility, and changes in the quality of your life. First, let's take a look at this week's Prairie Doc quiz question. Chronic pain syndrome is associated with one or more of the following. Number 1, chronic post-surgical pain. 2, chronic back pain. 3, chronic fatigue syndrome. 4, endometriosis. 5, fibromyalgia. 6, inflammatory bowel disease. 7, interstitial cystitis. 8, temporomandibular joint dysfunction. Choose the best answers or answer, and it may be more than one. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show, and remember, you only have 10 minutes to get your answer in for the quiz. But we answer your questions about orthopedic concerns all night as they are called in or sent to us via Facebook or email. Call in your questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are Doctors Pete Looby and Jonathon Geisinger of the Orthopedic Institute. Thank you both for joining us. Great pleasure. You've been on the show, what, 200-300 times?
Yeah, slightly more than that, but yeah, right in there.
Right in there.
Yeah.
So let's just talk now. John, you're new to the territory. Let's tell us a little bit about you. Where are you from originally, and what's your story?
Yep. I am very new to the Sioux Falls area, but I grew up in Spencer, Iowa, which is in northwest Iowa. I come from a long line of farm families there, and went to high school in Sioux Central, and then went to University of Iowa for 4 years doing med school and undergrad school there as well. And then I spent 5 years in residency out in Beaumont, Royal Oak, Michigan, which is one of the suburbs just north of Detroit. And following that, I did a year-long fellowship doing spine surgery up at Twin Cities with the Twin Cities Spine Center. And then after that, I was very fortunate to get a job at Orthopedic Institute and settle in here in Sioux Falls with my wife and 2 kids.
That's great.
Yeah.
So Beaumont, tell us a little bit about that, where you did your residency.
Beaumont's a huge orthopedic hospital. It's one of the biggest in the country. They do just a very high volume. They do everything from knees, hips, spines, absolutely everything. And it's a big level 1 trauma center with a lot of history too. There was a very famous surgeon, William Beaumont. He pioneered the hospital in the area and did some real pioneering things to investigate how the stomach digests food and things like that, with some really extraordinary experiments on a Native American.
Right, here's this Native American gentleman who was shot in the stomach, and there's a hole into his gut, and the hole stayed open, and Beaumont did all these experiments about food and how it dissolved.
He'd put different types of food in the stomach on a string, put it in there for a few hours, pull it back out, and see what happened to it. And it's actually from that, a lot of the work, and from what I understand, going all through general surgery and things, were developed for how we understand how things are digested.
I mean, it's in every textbook that I've ever read, about medicine. That is wonderful history. So that's Beaumont, William Beaumont, and that's where you're trained. And you're here now for 6 months, but you do just backs?
Spine is my thing. I'm fellowship trained in it, so I do a lot of cervical spine work, thoracic spine and lumbar spine. And then I'm trained in all of orthopedics, so I do a lot of trauma stuff as well.
So when you take your turn on the trauma call.
That's right.
Which is great. And Pete, you've been doing, what do you do mainly? What are your fields?
What I mainly do is call Jonathan when I've got a trauma case and have him take care of it for me, Rick.
Always happy to.
Yeah, 23 years now in Sioux Falls, and as you know, I'm up in Brookings every Tuesday seeing patients there. I have been for 15 years. Mainly knee and shoulder work, but I do hip replacements as well.
So, and you were an athlete in high school.
Well, some people remember that. A lot of people don't remember that. Yeah. Yeah, Lincoln High School. I was a 3-sport athlete down there, quarterback, captain of the football team a million years ago.
Yeah, that's fun. And when you did your sports training, you did that at Harvard? Tell me about that.
Yeah, so after I finished my 5 years of orthopedic surgery residency down in New Mexico, Catherine and I moved to the Boston area, and I did a year of orthopedic sports medicine training at Harvard and Massachusetts General Hospital, where I was team physician for the New England Patriots for a year and took care of the Boston Bruins, the Harvard University sports teams, and the New England Revolution. We had a great year in Boston. It was fun.
So, so are you still a Patriot fan?
Forever and ever. Oh yeah, I know. It's tough up here.
It's tough up here, yeah. Okay. Well, you know, this is a wonderful opportunity for people to call in questions. We really want you to give us your call. Go to the internet, give us a call. Please let this be your show. Direct our show and with your question. So back surgery is one of those really tough areas. I know that when you look at chronic pain syndrome, people who have pain longer than 1 or 2 months, it's a different bird. It changes. It's not the same thing as the pain you have after somebody cut into you or post-operative pain. And so you have a lot of different, you have to consider other modalities. What's your perspective on that whole thing about chronic pain?
Chronic pain, it can be such a debilitating thing for people. It does. It changes not only their mindset, but their physiology. It's something that you have to address the entire person when you're dealing with it. You know, their health, their wellness, their nutrition, everything goes along with it. Fortunately, there are several things that you can help with the right indications with what I do. And sometimes what I do might not be the best solution. So we also have a lot of other things that we can try for people, and different physicians in our group, they can also help with those things as well.
You know, there was a big study in Texas where one town, there was a whole lot of orthopedic surgeons and they were doing back surgeries right and left. And the next town nearby, they weren't doing nearly as many. They were just doing very conservative. And the result was equal amount of pain, equal amount of results, but a whole lot more money was spent in the one town. Explain that story, and what's the take-home message, and how do you feel about that story?
You know, how I feel about dealing with people's pain and surgery in general, and some people do possibly do things maybe when they shouldn't be done. And I think it just falls back to solid indications and doing the right thing for the right reason. And spine surgery is one of those things where it's very complex, and it's sometimes very difficult to decide what is the right thing to do and when should I do it. And really, if you just go back and follow the guidelines and use very solid indications for each and everything, people can have just extraordinary outcomes if done for the right reason.
Right. I've often said that the reason for sure is when they're starting to lose the muscle function. You know, foot drop starting, you can't raise that foot up, you can't, your function is going. I know it's more complex than that, but that's the biggie for me.
That's so true. Progressive neurologic deficit is what we call that. So if somebody has a leg that's weak or a foot that's dropping, or they're losing control of their bowel or bladder or things like that, those are things that should be addressed sooner than later, because a lot of those times, if you do have those deficits that develop, oftentimes they're not reversible. So it is something that you do want to stay in tune with and to treat sooner than later.
And I've seen marvelous changes in certain people who have pain. The surgery helped, made a difference. But then there's also the many people who, really the treatment is non-surgical.
Yes, absolutely. Physical therapy is great. Chiropractic can be very beneficial. There's a lot of different modalities that we have to offer people, and surgery is really, it's the end thing that we do for people. Okay. It's after we've tried everything else.
It's the last.
It is.
There you go. It's the end thing.
Yep.
But on your side of the story, Pete, I see people who are losing function. They're not walking. They're not able to actively do the things that keep them healthy for their heart and their lung. And if you can get them a new knee or a new hip, it's a remarkable story. Now they're back to walking again. And I think we need to be more aggressive in our treatment modalities in that regard.
I think we think about those patients the same way John thinks about his spine patients, Rick. You have to fall back on your training, your experience, the peer-reviewed literature, and when the indications are right, then operate on those patients. It doesn't make any sense to be putting new knees into your 30-year-old patients who got knee pain. They probably have got another reason for their knee pain that we need to address. But as you are well aware, knee replacement surgery was sort of the miracle operation of the 20th century and gave a whole generation of people their mobility back. So as you said, they could stay active, have that healthy lifestyle, support the other organ systems so that they weren't degenerating as quickly.
Yeah. I read an article in Scientific American. My good friend, Dr. Don Evenson, who is a spermatologist friend, who is an expert in male fertility. But he read, these Scientific American things showed that gorillas and chimpanzees and those kinds of animals are usually pretty lazy, and that there's a huge difference between genetically they are our closest relative of the animals to the humans who walk. The typical hunter-gatherer societies walked anywhere from 8 to 12 miles every day. They were constantly moving, and we need to do that, or we end up with heart disease or lung disease or kidney disease. We are genetically made to be active. So we've got good questions coming, and so we'll jump right into that. Sorry. I need 2 hips in less than 2 years. Is it possible to do the replacement hips the same length so that to avoid messing up the back? I've seen people walking sideways because one hip is longer than the other. This whole thing of hip being the right length.
The biggest complaint that people have after total hip replacement is leg length discrepancy. You got one leg that's a little bit longer than others. We do everything we can intraoperatively, starting with our evaluation and our imaging before surgery, to keep that leg length the same as we can, or as close to the same as we can. I will tell you, is sometimes it's not possible. There's this sort of push and pull. You want the leg to be the right length, but you also have to have the hip be stable. And sometimes you have to make the leg a little bit longer in order for the hip to be stable, because nobody wants their hip popping out when they're walking down the sidewalk.
Right.
So I try to remember to counsel my patients preoperatively. There may be a leg length discrepancy. We try really hard not to have that happen. There are ways to treat it afterwards with shoe lifts, et cetera, that can alleviate some of the difficulty of having that one leg longer than the other. And as far as how that affects the function of the lumbar spine, I would leave that to Jonathan.
Yeah, any comment, John?
People, when they have an offset in their limb length, sometimes that can lead to some back discomfort. I would also add to that is a lot of times if people have one bad hip, and a lot of times the other hip is also going. So a little bit later on down the road, if you do have another hip replacement, that's a time when you can actually equal those legs out, and I've seen that happen several times. But yeah, oftentimes, not as much just when people have hip replacements have I seen it, but a lot of times when a patient, like a pediatric patient who has a really severe limb length discrepancy that wasn't addressed at a younger age with a lift or another technique that could have helped them, that does lead to maybe some scoliosis later in life, and a pelvic tilt and things like that can lead to some back problems.
The cause of scoliosis, of course, is you have the answer to that?
Not yet, not yet. There is genetic testing, but where you can help kind of preventively even identify it. But there are a lot of surgical things for scoliosis that we use for the pediatric population, and under the right circumstances, that has just absolutely changed the course of that disease process. I mean, we don't even see kids walking around anymore like they did 50, 100 years ago. So
because of
really
the lifts and the...
No, that would be more with the rod corrections and the things that we do with surgery for the big pediatric scoliosis deformities, where they used to do body casts and all these kind of things.
Yes.
That's actually where orthopedics got its start. Ortho meaning straight and pediatric child. So orthopedics was started with the spine and identifying scoliosis in kids and going on to correct it and things like that.
Wow. If you get your knees replaced, is it common that they still hurt, Pete?
If you look at 5-year after surgery data, about 5% of people are unhappy with the amount of knee pain that they have. I tell my patients, don't be surprised if you have a little discomfort. The goal here is not to make you perfectly pain-free like you were when you were 18. Our goal is to make you better than you were before so you can have that healthy, active lifestyle, enjoy your recreational and work activities, get decent rest at night. It's not to make it perfectly pain-free.
Well, and isn't it also true that the rehabilitation history really reflects how much pain they will have? If they don't really push hard and start moving that new knee and start using it, that the people who are reluctant are the ones who have more trouble postoperatively.
There's no question that people who are not compliant with their postoperative rehabilitation are more likely to fall into that category of people who have more pain. There's a lot of work that's been done over the last 5 to 10 years in trying to identify preoperatively who's likely to have more pain after surgery. Being a little overweight, being deconditioned, being on opiates before the surgery. Those are all red flags.
Bad signs. Pain is a great motivator to seek help, but even with a successful surgery, you, the patient, may have to work to do before you can get back to full health.
I had really a lot of pain in the hip joint, especially on the right-hand side, down the leg, some on the left side, down the leg, and no pain in the back, but the MRI showed cysts on this that were growing into the spinal cord, and they'd compressed it probably from roughly a ½ inch diameter down to about ¼ inch diameter, and that was causing some irritation. I had an MRI, then visited with Dr. Geisinger. He was recommended by my local doctor, Dr. Warren. And so we sat down, we talked about it, we go over what it looks like on the MRI, and he prescribes what's needed to be done. And he says, what we have to do is go in and remove those. It looked like at that time 1 cyst. So from there you schedule it, and we scheduled it for December 6th. And from there on, you go in and you have the process done. Now, it turned out there were 3 cysts on it. The largest one, they were not able to remove the total thing because they're working on that. It's grown in a little bit, and so they make a value judgment on how much they can get out. But I've had 0 symptoms of the type I had prior to the surgery ever since the surgery. People are apprehensive about those type of things. That's a natural thing to do. But it was done at Avera, and the nurses, the doctors, the PAs and that, you hope they would do something at a particular level, and they exceeded that all the way through. You also go through a set of therapy activities to strengthen muscles and that sort of thing. And I was really pretty conscientious about doing that. First of all, they gave me some elastic bands, and I did exercises with my legs. Then they did prescribed a set of exercises where you're strengthening your core muscles, especially the stomach muscles. And that's a progressive thing. As I progressed through that, then they continued to give me increasingly strong rubber stretch items for the legs, and then increasingly difficult things to do for the stomach muscles. And then last Wednesday, which was the 13th of March, go back again, and now I'm at 50 pounds. I can't play golf. They won't let me do that until probably 3 more months after that. So it's an extended period of time, but this wasn't microsurgery. They had to go in and take these things out, and so you got some healing up to do. They had to remove some bone to get in and do the process they wanted to do. If you're having problems, go see professional people that are good at what they do, and then trust their judgment and trust their ability. That's the best I could say. And then if you want to, if you happen to be a religious person, say thank God for there's people that are capable of doing that. They do it, and they do it well.
This is your program, and your questions are key to the direction of our discussion. Please call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org. Well, the last case, Jonathan, was your case, right? Tell me a little bit about we've got an MRI of what he presented to you with. Explain it.
That's right. So this is a MRI image that we have of Milo, and what Milo came in with is he had a lot of symptoms that were going into his buttock and into his thighs, and what we call that is neurogenic claudication, which just basically means he had a lot of tightness in his spine, and that was causing symptoms to go down into his legs.
So where are
this MRI image, this is an image from the side, so it's like taking a slice, looking at somebody from the side, looking in. On the front side here, this is the front.
Okay.
And over here is the back.
It's not drawing though, I wonder.
Do this.
It's not drawing.
Let me try that one.
Touch this one. So keep right.
So in the very middle, you can see he has a big circle, and this big circle is where he had the cyst, and that cyst was causing a significant amount of tightness on his spine. So it's right at the disc space, and it's causing a lot of tightness right there, and that's what was pinching on his nerves. Above and below that, you can see the nerves, and they have lots of room, and the white indicates that they had fluid around them, and they did have enough room.
Okay. Now, we have another slide?
Yeah, we could go to the next slide.
Try this one up here again. So,
we can go to the next one.
go to the next slide. So here we go. There we go.
Okay. So the next slide, we're still on the previous
Well,
slide.
circle the spot.
So this is the spot I was talking about being tight.
Okay.
We
Okay.
could go to the next one.
And then we have a emergency technologist who is going to come in here, and here we go. Yes. So the next slide, we're going to have to work on this system. So Lowell, can we go to the next?
Are we on that picture or this picture?
Oh, the picture. Yeah. So what do we have here up there on the
Up on the screen now is what you see in the very middle is a picture of an image, and that's like cutting your spine like a loaf of bread, and that's an image from an MRI. And in the very middle is the cerebral spinal fluid, which is the fluid around your nerves. That's the bright white, and those dark little dots in the middle, those are the nerve roots that go down through your spine and eventually go down to your legs and all the muscles. You can go to the next slide. Maybe the previous one, that one. And that very dark kind of circle right in the middle with the very light in the middle, that's Milo Cyst that he had inside his spine. And that was pushing, and before you could see the nerves in the spinal canal, now you can't see those at all. So that was that severe tightness that was pushing right on his spine, causing him to have all the symptoms that he had. So with surgery, I just very simply went in, made a small incision, went down over the back part of his back, and I took off a little bit of bone, and I was able to take most of that cyst away and empty it. There was just a very small part of scar tissue that was left in there, but it was relatively and completely decompressed for him, and gave him just wonderful relief of his symptoms.
when you can have surgery that can actually relieve the symptoms and save a person's function, because he's going to lose the function probably incontinence and so on and so forth.
That's right. And what's so remarkable about this is he goes from having these symptoms one day, and literally right after the surgery, he's back up and walking. And it's just it's an extraordinary outcome, and he's a really extraordinary individual. So I was very privileged to have the opportunity to take care of him.
Yeah. Soon to be golfing.
Yeah, yep. We're going to let him do, he can do putting right now, but I told him to stay away from the long drive.
Well,
for a
but you
while.
know what? The putting game is always important, isn't
That's
it?
right.
Yeah. Okay, so I've had surgery, spinal cord stimulator, injections and therapy and everything possible. What else can I do to alleviate my excruciating chronic back pain? It's gotten to the point where it's debilitating me. That's a tough one, Jonathan.
It's tough, and that's the toughest thing that I come across is people that have already had a lot of things done, a lot of things tried, and just nothing's worked for them. So really, and I see a lot of these in clinic, and what I do is I start over from square one. I look at the imaging. If their imaging is way out of date, we get some new imaging and just see, is there a mechanical reason? Is there something that maybe somebody else missed that I can identify to maybe give that person a little bit of relief? But oftentimes it's a complex problem, and it's something that really takes a lot of thought and time and diligently looking over to see if there's anything I can do for it.
So we have another caller, has had pain in her knee since January, has a Baker's cyst and bone spurs in that same knee, as well as tearing in the quadriceps tendon. Last year they ruptured their quadriceps tendon on the other leg. They want to know where to go from here to get rid of the pain and become functional again. Pete?
Well, it sounds like there's two processes going on here, Rick. Not only we got some damage to the quadriceps tendon, which may need a repair, but there's also sounds like there's osteoarthritis in the knee, and that may need treatment. So this person, I think, would be a great candidate to get into see their orthopedic knee specialist and get evaluated and get appropriate treatment at this point. I wouldn't wait on that one.
So it sounds like something that needs surgery.
It might.
Now the quadriceps is that big thigh, top of the thigh muscle above the knee.
That's correct. Yep.
And that explain that a little bit.
So that huge muscle can be the largest muscle in the body on a lot of us, and comes down, and then it kind of cones down and becomes a big tendon that attaches to the top half of your kneecap or your patella. And it's not common, but it's not all rare for that tendon to be damaged, especially if we get over the age of 55 or 60. And it's been a number of patients nationally that we all have heard about who've ruptured that quadriceps tendon, and locally some of our prominent citizens have ruptured that, and it does require repair when it tears.
So, I mean, football players mostly?
No, typically your young, active individuals will not rupture their quad tendon. It's more likely to be older individuals who have
who play basketball into their 50s.
Yes, right. Something exactly like that, yes.
I had a partial knee surgery about 9 months ago. My knee seems to have gotten worse. I've consulted another physician who recommended a total knee replacement. Is there anything else I could do instead of to alleviate some of the pain? So partial knee surgery versus a total knee surgery, I mean, what are the indications? And will it, if you do the total knee, will that take away the pain?
Yeah, that's a great question. It can be a difficult problem sometimes. Let's start out with total versus partial.
Okay.
I love doing partial knee replacements, but you have to pick the patients correctly. If you do partial knee replacement on the wrong patient, they're going to be unhappy with it. If you pick the patients appropriately, they're likely to have a fantastic outcome, and they will recover more quickly than your patients with total knee operations. Now, if the patient still has pain after their partial knee replacement, you have to determine why they're having the pain. If the problem is unrecognized and untreated arthritis in the other half of the knee or behind the kneecap, then it may be necessary to take the partial out and put a total in. But there's a lot of other reasons that knee can hurt and may not require surgery. So a good evaluation. I'm glad they've gone in and been evaluated. Never a bad idea to get a second opinion in a case like that.
So when you have a knee, you've got the upper bone and the bottom bone.
Yes,
right?
That's right.
A partial knee is just the upper or just the bottom?
No, it's one half, the inside half or the outside half, but you do both the upper bone, the femur,
yeah,
and the lower bone, the tibia.
Oh, so it isn't one side, it is the half, the outside or the inside?
Or the inside, right.
So then if you have a guy who is bow-legged, for example, which means that, you know, the knees going out, then you fix the outer half.
Inner half.
Oh, the inner half.
The inner half usually in that case, yes.
And so it's the other way around when you have someone who's knock-kneed.
Knock-kneed, right, exactly.
There's a fancy word, valgus and varus and all that, and I've never been able to remember those.
You don't need to.
I call you. Caller has stenosis in the back. Pain has changed, moved. How does stenosis work? Is pain changing normal? Horrible pain started in the butt and has moved into the legs and then backs off. Is changing worrisome. So now, first of all, explain, Jonathan, what is stenosis? Spinal stenosis, we've heard that a lot. What is that? And then this person has kind of a moving discomfort. What does that mean?
So first off, spinal stenosis, it's basically just means tightness around a nerve. And in your lower back, you have the nerves in the spinal canal that come down, and you can get a central stenosis or a central tightness.
That's squeezing the whole spinal canal.
That's right, and that's kind of what Milo had earlier in the show, where it was squeezing his nerves in the spinal canal. That presents with pain in the buttock and in the upper thighs and can kind of go down into the thighs as well. And it tends to be progressive in a lot of people. When you have symptoms where they're kind of shifting from one spot to another spot associated with some back pain, and then it's some buttock pain, and then maybe sometimes it's going down the leg as well, those can be not only stenosis, but a secondary thing as well called instability, where maybe one vertebra is slipping, and when that slips, maybe it pinches a little bit different each time when it slips, and can cause those different symptoms that people have. And when it slips, it then also can cause that stenosis or that pinching that can cause the symptoms in the leg.
That's the spondylolisthesis?
Yep, spondylolisthesis, that's right, you got it.
Pretty good for an internist, I would
That's
say.
right, it's phenomenal.
A Huron man had a knee replaced 9 weeks ago and is 68 years old. Their recovery is going fantastic according to their doctors. However, their knee makes a noticeable audible clicking sound when they're walking. Their therapist said that's good because it means it's loose enough.
It's neither good nor bad, but it's extremely common. You know, a normal knee is made out of bone and cartilage. It has what we call a very low resonance. If you take those two surfaces and hit them together, they don't click, they kind of have a soft thud. But the artificial knee is made out of metal and plastic, has a very high resonance. You take those two surfaces together, they do go click when you hit them against each other. People, that can be audible. You can actually hear it in a room when it happens sometimes, or sometimes the resonance is just being transmitted through the skeleton to the inner ear, and you're hearing it, but nobody else is. Right? Yeah. Nothing to worry about. Completely normal. I do know. I mean, after 5,000 knees, my impression is people stop talking about it. I don't know if it goes away or they just get used to it, but I never hear it 2 years later. At 9 weeks, you hear it all the time, right?
It's clicking, oh my God.
What have you done to me? My knee is clicking. I think it's okay.
So that's very interesting, that it goes away after 2 years, whether it really stops clicking or whether it, that's so interesting. With spondylolisthesis, and I'm going to have you define that again, can people still do active sports? Does it depend on what grade it is, what makes it better or worse? So let's again, so we have our spinal column and one kind of shifts forward, right?
That's right.
Why did people have spondylolisthesis, and what makes it worse, and what kind of problems you get?
There's many different reasons why you can have spondylolisthesis, and spondy basically means spine, listhesis means movement. And so that means a spine that moves, and it's a spine that moves abnormally. Normally the spine keeps the stable alignment, it can rotate a little bit, but when it starts to slide or translate in a direction, that's an abnormal motion for the spine. And so that's what can create a lot of symptoms for people. And so the second part of the question was with what sports and things can they do? Typically, and going by the literature and things like that, and a lot of experiences, They can slowly progress in some people, but typically it's not going to get to the point where you're going to have an emergent situation. You're going to know that you're having more pain or some onset of numbness or tingling, and you're going to go and see somebody and be evaluated sooner than later for that. But you can do sports and things like that. I encourage a lot of people that have slips to go do physical therapy. If you can work on your core muscles and your stomach, your all of these abdominal muscles translate to having like an internal binder or a corset that can help stabilize your back. So if you just do a little bit of core strengthening, that can actually give a lot of people relief of their spine slips.
Don't you think we should all have core strengthening and prevent this back trouble that we were going to get when we get into our 50s and 60s?
Ideally, yes.
So what is a simple core, 1 or 2 core strengthening exercise that would be most important?
So planks are great, or push-ups, things like that, where you're down and maybe on your elbows and you just hold it for as many seconds as you can. That strengthens those big muscles in your back that helps hold the vertebra in place. Unfortunately, people that do have these slips, they just get so much pain, they get so deconditioned that they can't jump right to that thing and just do that. That's very difficult.
Okay.
So that's oftentimes when we have them work with a therapist to help retrain their muscles to understand what to activate and how to make it stronger.
All right, the answer for spondylolisthesis is the right exercise.
Exercise.
Plank. Make yourself a plank. Dr. Looby, do you remember Dan Loring and how you broke my left leg in 34 places and how you saved my leg?
I do remember Dan. Dan's a large individual. Dan, I hope you're doing well. Thanks for calling in.
So he had 34 pieces and you ended up put a rod in and then shoving all the pieces through the rod?
Yeah, a very, very difficult case. Tough problem for Dan, but he was a great patient, did everything we asked him to do, eventually healed up and did well, and it's great to hear that he's out there and doing well.
Hello to Dan Loring, and thanks for calling in, Dan. As a 71-year-old female, I've noticed recently I can hear my neck crack when I move my head sometimes. There's no pain. Does this mean anything, Jonathan?
If there's no pain and no issues in your arms or your legs, nothing's radiating down, no weakness, no numbness, it's a good chance it's arthritis. And just like any other joint that gets arthritis and maybe can start causing some issues and things like that, the neck is no different. A lot of times too, as you develop arthritis, you kind of get these bone spurs. And there's just literally hundreds of little tiny muscles on your spine. And as your spine twists or moves a little bit with those muscles, those little tendons can pop over those small little bone spurs. And that's sometimes that feeling or sensation or sound that people hear when their neck is crunching.
I kind of like the idea of, yes, exercise, no exercise, and then I don't know exercise, which is ear to shoulder. Do you recommend those, or is there a danger in encouraging?
No.
movement?
As long as you're not having some weird electrical signal that some people can get when they look up and down. If they have that, that's something that they need to be seen for. But if they don't have that, no, neck range of motion, as long as it's not too painful, there's a lot of great exercises and stretching that you can do to help prevent neck issues.
Lots of yeses, lots of nos, and then ear to shoulder.
More yeses than nos.
More yeses. So an 88-year-old Lennox woman says she has pain in her knuckles and joints at night, but do not have them during the day. What can she do for that? And what about cracking her knuckles?
Yeah, they'll start with the last question. As far as I know, cracking your knuckles is nothing. Nothing to worry. So I think we were all told as kids, don't crack your knuckles, you'll get arthritis. I don't think that's actually a thing.
Okay. All right.
The pain at night, or especially if it's there first thing in the morning, but think it's better during the day, can be indicative of rheumatologic conditions, and so probably worth a blood test to take a look.
Yeah, see your primary or a
See your
rheumatologist.
internist. Well,
your internist.
Well, you can't see the rheumatologist for 8 months. You know that.
see
So
the
you got to go
internist.
see the internist,
Yes.
right? So.
It all starts here.
Right.
Sioux Falls woman says, I have had a meltdown of my muscles for the last 9 months. Spasms twist me into a pretzel. I have a drag on my right leg that affects my walking. I'm 91 years of age. Is there anything that can be done other than surgery? Ooh, that's an interesting question. I'm worried about her. But is a 91-year-old person a good candidate for surgery? Do you start doing MRIs and CAT scans and stuff like that?
You know, I don't look at people based on what their
Age is.
their number is. It's more physiologic. What is the person like? How active are they? How do they feel? How vibrant are they? Those are kind of the things that make up who people are and what we can do for
And
them.
if she's still going and moving and shaking, you would do those
These sound like some pretty significant symptoms she's having, and I'd be worried about maybe something in her spine, maybe something else, and I think it would warrant at least finding out, doing an evaluation to see what it is.
Get on in and see Jonathan. This person has piriformis syndrome in their hip. What is this, and is there a cure? Piriformis, Pete?
John knows a lot more about piriformis syndrome than I do.
John?
It's a complex problem. It's so hard to delineate piriformis from low back, and that's why Dr. Looby put it over towards me, because it's the same nerves, the same symptoms can come about. There's some different variations on the piriformis muscle that people can get those kind of symptoms. So really it starts with an evaluation of your low back, and then from there there's some other tests. So you start with the easy things, and the easy thing is look in the low back with some imaging to see if that's it.
So we've got a lot of questions and not much time, so we need to be pretty quick on our answers.
Rapid fire.
Rapid fire.
All right, here we
A
go.
lead woman asks, I've had low back pain for 20 years, had MRI, problem with left hip, degenerative bone disease in knee. Is this all connected, or are there separate issues? How many times people present with back pain and it's really hip?
You know, it's almost more the other way around. People present with hip pain, and it turns out to be their back. I think bottom line for this woman is probably at least 3 different problems needs to be evaluated.
Right, good. Brookings woman says, I had my knee replaced about 13 months ago, and it's still rather numb. How long is this going to last?
Yeah, so it happens every time. Whenever we make a vertical incision on the knee, we denervate the outside skin. I try to remember to tell all my patients before and after this is going to happen. I like to show them my own scars and remind them that those are 38 years old now and there's still a little numb around the scars. The answer is it will get better. It takes a long, long time.
Okay, good. Can you explain or comment on degenerative disc disease in Pars defect? Cause and treatment, Jonathan.
Pars defects tend to lead toward instability sometimes, and that's when you have that slip like we were talking about before. When you do have abnormal motion, that also lends to degenerative disc disease, so the things can kind of go hand in hand.
Okay. You know, everybody talks about disc disease, disc disease, disc disease. How much really is it disc disease?
I definitely think that disc disease can be a real source and a legitimate source of pain for people. But how you treat that is the important thing, and it's surgery for degenerative conditions of just disc disease to not give you a good predictable outcome with doing surgery for that.
Wow. A woman from Wakanda had reverse shoulder surgery 9 years ago, and her upper arm still hurts. Why is this? What is reverse?
So shoulder replacement surgery, a new ball and a new socket. They're standard where we put the new ball where the old ball was, the new socket where the old socket was, or reverse. And these are usually for patients who don't have a good adequate rotator cuff. If you do a standard shoulder replacement on them, it tends to be painful, it tends to fail early and not do well. 15 years ago, the FDA approved in this country the reverse shoulder, and it is a miracle operation for patients who have bad osteoarthritis of their shoulder and no functioning rotator cuff. It's unusual for this patient to continue to have pain this long. I think it probably needs an x-ray.
Wow.
Or it could be coming from the neck.
Or could be from the neck.
Could be from the neck.
Aha! A woman from, reverse shoulders. So there's a ball and a socket the other way around.
Yep.
Isn't that interesting? 72-year-old spearfish woman says, my posture's getting worse every year. Can I do something to prevent this? Posture issue. Very quickly, we got 30 seconds.
My favorite line is, life is a kyphosing event, meaning that gravity always pulls us forward no matter what we're going to do. Our whole body is set up to fight gravity. What can you do? Exercises, physical therapy, and sometimes it's just a bone thing. Watching your bone quality is another
How about
important
position
thing.
when you sleep at night? Instead of curling up like a little ball, try to arch a little bit. Does that make a difference?
Not that I know of. I think just keeping a nice neutral spine, so whatever is comfortable is the key.
A Rapid City man asks, discuss rotator cuff surgery, explain what happens to muscles as well as what happens during the surgery.
So the muscles are attached to the tendon. The rotator cuff, when we're talking about a tear of the rotator cuff, we're talking about the tendon. We repair the tendon, which essentially reconnects the muscle to the bone. The muscle's job is to contract, pull on the tendon, which then moves the skeleton. That's the way all of our joints work, the same way the shoulder works with the rotator cuff. So the answer is repair the tendon, rehabilitate the muscle. You expect function to come back over time.
And shoulder surgeries are so much better, so much more successful in the last 10 years even. I mean, I remember, but we moved forward. Canton Man asks that we talk about Medicare protocol. He had 4 spine surgeries. Because he's on Medicare, it was hard to get it done. Is Medicare frustrating for the doctors as well?
The question of the day.
And we've got less than 30 seconds.
I would say Orthopedic Institute, we just have a phenomenal support staff that helps guide people through that whole process. For me, I get to focus on the patient and doing what's right for them and doing hopefully a really good surgery for them, and I'm just very lucky to have a wonderful staff in place that helps me do that.
A Sioux Falls woman asks for the doctor's opinion on Synvisc injection of the knee.
So Synvisc injection is one of the viscose supplementation injections. It's a polymerized form of hyaluronic acid. Hyaluronic acid is a normal constituent of our joint fluid. It's what makes it thick, makes it slippery. As we age, as we get arthritis in our knees and other joints, we lose the hyaluronic acid. The lubricating fluid becomes more like water, less like motor oil. It thins out, doesn't do a good job just when you really need it because the joint's wearing out. And Synvisc or other viscose supplementation injections are a way to get that hyaluronic acid back into the joint.
Does it work?
Yeah, sometimes.
Sometimes works. I've got one last question. Right hip, still having trouble with pain. We've got 15 seconds, doing PT and core strengthening. What else can he do?
If you could try an intra-articular hip injection to find out maybe that is or is not the legitimate cause of the pain. So try that to see if that's it.
Very good. And now for the winner of tonight's Prairie Doc quiz question. Chronic pain syndrome is associated with one or more of the following: chronic post-surgical pain, chronic back pain, chronic fatigue syndrome, endometriosis, fibromyalgia, inflammatory bowel disease, interstitial cystitis, temporal mandibular joint dysfunction. Choose the best answer, and it might be more than one, and the answer is all of the above. It's any of those. It was Marianne Godel, hopefully I pronounced that right, Marianne, who answered the question correctly. Thank you for participating, and a book will be in the mail to you soon. We'll be right back after this.
Welcome to your Prairie Doc Library at www.prairiedoc.org. Wherever you live or travel, you and your family can enjoy free and easy access 24 hours a day. Search for a specific topic. Browse through the television shows, radio programs, and blog page. You, your family, and friends around the world can learn from physicians and other health professionals answering questions on a variety of medical topics. Visit your Prairie Doc Library today at www.prairiedoc.org.
Starting sometime in the Middle Ages, throughout many lands, there were bone setters who knew about splinting, how to treat broken bones with splints made from sticks, leather, and clay. They even had a guild, a medieval union of a sorts, a cohesive group of workers organized to ensure quality, consistency, in education. Medical schools for physicians existed at that time, but bone setters, along with the surgeons, didn't attend those schools. In the 1700s, Nicolas André, a researcher and professor of medicine at the University of Paris, formally described splinting, a technique used by bone setters, as a method to treat bony deformities such as club feet in newborn children. He likened it to the straightening of a young tree sapling. André wrote a textbook on the subject entitled L'Orthopédie. The ancient Greek word orthos means free from deformity, to straighten. The ancient Greek word paideia refers to the art of raising a child. Literally, orthopedics means to straighten the bent bones of children. Together, they provide for the name of a present-day surgical specialty. Surgical methods in the 1700s and 1800s were very immature. Anesthesia was first developed during the early 1800s, and ether was widely used during the Civil War. After the Civil War, surgeons brought their surgical experience home to small towns throughout all of the U.S. It wasn't until after the war that we learned of bacteria and discovered we could avoid infection following surgery. In addition, X-rays were discovered by Wilhelm Röntgen in 1895, which allowed for the marvelous and revealing image of our internal bony structure. These advancements helped set the stage for expanding the focus of orthopedics from casting and making straight the bony deformities of children. In the 1890s, Evan Thomas, a well-known bone setter from Liverpool, England, encouraged his son Hugh to go to medical school. While learning medicine, Hugh learned from his father bone setting and casting methods, which at the time were not being taught in medical schools. And Hugh was influential in bringing this curriculum to medical schools. In practice with his nephew, Robert Jones, these two worked to develop orthopedic surgical methods in treating bone injuries in construction workers, and then World War I injuries in military men. Thus, we trace the evolution from bone setters and straightening the bones of children to anesthetized yet unsterile amputations during the Civil War, to bone setting taught in medical school, to surgical repair of bony injuries in World War I, and to the marvelous and ever-developing field of orthopedic surgery. A big thank you to our guests, Dr. Looby and Dr. Geisinger, for volunteering to come to our studio in Yeager Hall on the campus of South Dakota State University. There were many great questions we were not able to get to during our broadcast time. We will continue to answer those questions on our Facebook page following the program tonight. Go to the Prairie Doc Facebook page. We'll be there shortly after the broadcast ends. This additional segment will also be posted on our website, prairiedoc.org, in the coming days. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
With the coming of spring, we move right from flu season to allergy season. Allergies, nothing to sneeze at. Next time on Call with the Prairie Doc.
Useful, scientific-based medical information delivered in a respectful and compassionate manner. This is what we get from the Prairie Docs. I am proud to serve on the board of the Healing Words Foundation. Our nonprofit organization works behind the scenes building financial support to continue and expand Prairie Doc programs. We thank the many health providers who volunteer their time to answer our health questions. Significant funding is required to produce and distribute video, radio, and print throughout the region. Your donations will help the foundation continue to offer free and easy access to the entire library of Prairie Doc health education programs. I grew up with Rick Holm on the prairies in DeSmet. On behalf of the Healing Words Foundation,
And on behalf of a lifelong friend,
we invite you to join our mission. Go to prairiedoc.org and click the donate button today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota,
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians,
Avera Heart Hospital,
Dakota Allergy and Asthma,
CoBank,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
Black Hills Medical Society,
Aberdeen District Medical Society,
3rd District Medical Society,
7th District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy,
and Swiftel Communications.